Hi everyone. In this session, we're going to speak about bronchiolitis in children. So, bronchiolitis is essentially inflammation of the bronchioles, usually caused by an acute viral illness. So, if you try to understand the the passage of air entry into your mouth, going down the trachea. So, obviously, that is your mouth. Um, So following in the respiratory system, you usually have your trachea, or you always have trachea, which it branches into your two um, bronchioles, right? Bronchi, sorry. You have your left and your right bronchus. There's your right lung, there's your left lung. And then the bronchi, each bronchus basically then branch further into bronchioles, right? Okay. So that inflammation, so basically inflammation in the bronchus, so could be either over there or over there. Okay. And you can imagine that it's causing occlusion. Okay. So um yeah, inflammation and it is the most common lower respiratory tract infection in children younger than 2 years of age. Okay, so we say that it's a viral infection. Okay, viral infection causing inflammation, common lower respiratory tract infection. So lower respiratory tract infection and kind of the risk, one of the risk factors is less than 2 years of age. Okay, so less than 2 years of age. Respiratory distress impedes appropriate oral intake. So basically, children tends to don't want to eat, right? Resulting in frequent visits and admission to the hospital. And it's kind of one of the most common reasons for hospitalization for younger children of 2 years age during the winter periods. Okay. So the most common infectious agent causing acute bronchiolitis in children. So let's speak about the etiology or the cause. Okay, just use pen quickly. Okay, so in terms of etiology, the virus that we spoke about, um, the virus causing bronchiolitis is the RSV virus, the respiratory syncytial virus. Okay, RSV. So with the respiratory syncytial virus. Okay. RSVs envelope non-segmented negative single-strand RNA virus belonging to the paramyxovirus family. Um, Other viruses that cause this condition include adenovirus. Okay. Um, just put over here. Okay. So other viruses include the adenovirus, human metapneumovirus, okay, human metapneumovirus, the influenza virus, and para-influenza virus. Okay, so those are other types of viral causes for bronchiolitis. If an adenovirus is identified, most clinicians use it to tailor investigations because the natural cause of infection often presents with a prolonged febrile illness. So if it's more adenovirus, kind of prolonged febrile, um, the human metapneumovirus is not tested routinely. This ecological agent should be suspected when the patient tests negative for the RSV. So if the RSV is negative, we tend to go towards the human metapneumovirus. It should be suspected. Okay. Um, okay. So in terms of the pathophysiology, so again, we said that it results as a result of inflammation. Okay, so I should just put your pathophysiology. Okay, so in terms of the pathophysiology, so is inflammations. The keywords is inflammation of the linings of epithelial cells with small areas in the lungs causing mucus production. Okay, so this inflammation, right, causes mucus production, inflammation, and cellular necrosis. Okay, of the lung, of the bronchial of the structure of your bronchioles. Okay, and this inflammation of these cells can obstruct the airway, and that can result to wheezing. Okay, so that leads to airway obstruction, which essentially leads to your wheezing. Okay. In terms of history and physical examination, history and history and on physical exam. Okay. So on history, the initial presentation is that of, can you just branch out like that? Okay, so on history, the patient presents with a runny nose, nasal, runny nose, nasal congestion, okay, decreased appetite, okay, and cough usually for approximately 3 days, okay, so you have 3 days history of the cough, right? So as the disease progresses, tachypnea, there are certain features that develops, right? So that's on history. On examination, so on physical examination, what ensues on physical examination? Okay, so there's tachypnea, okay, increase in respiratory rate, use of accessory muscles, um, accessory respiratory muscles. Okay, so intercostal, right? We have intercostal and subcostal recessions or retractions, and wheezing can develop. Okay, because of that occlusion in the airway as a result of that inflammation. Okay. Um, Eventually, so those are kind of starting off signs, but there are kind of more signs of physical exam. Rather, I'm going to call it physical features. Okay, physical or clinical features. Um, Clinical features. Okay, so as the disease progresses, the child can develop grunting. Okay, um, nasal or alar flaring. Okay, they have cyanosis. Okay, it's not getting enough oxygen in the blood. Eventually hypoxia. Um, and increasing the CO2 cyanosis and eventually the respiratory failure if it's not treated as soon as possible. Okay, so it's therefore very important to monitor children, especially young infants, with this illness. Fever can sometimes be present. Um, so yeah, so basically on history, I mean, um, plus minus, meaning they could or could not be a fever. Okay, so patient doesn't have to have fever if you have a bronchiolitis. And then in some cases, urine analysis of urine culture can be considered to rule out a UTI, especially in uncircumcised males. Okay, so I think I'm going to stop there with regards to. Okay, wait. I'm just going to mention the evaluation or the investigations of bronchiolitis, and then in the next video, I'll speak about the treatment, management, differential diagnosis, and prognosis. Okay. So with regards to the workup or basically investigations of children with bronchiolitis, okay. So bronchiolitis is it's kind of mainly a clinical diagnosis. The diagnosis and severity of the illness should be made after eliciting a good history of present illness and based on the clinical manifestations of the patient. Investigations for patients with bronchiolitis include identification of the virus. Okay, so identifying the actual virus. There are commercially available rapid diagnostic assays which include immunofluorescent and enzyme immunoassay techniques for detection of viral antigen in nasopharyngeal specimens. Okay, um, so they are immunofluorescent and enzyme immunoassays. Okay. So this results in basically how clinicians to tailor the appropriate workup and management. The information is also valuable for placement as well as isolation and grouping hospitalized patients. Chest X-rays are not routinely done because typically these include non-specific findings such as hyperinflation, interstitial markings, and peribronchial thickening. So chest X-ray, nope. Chest um, X-ray is not routinely done. So I'll just strike through that. Okay. So yeah, so basically the session covered the etiology of bronchiolitis, In children, the pathophysiology, clinical history and clinical feature, and a little bit on evaluation and what, and that's not necessarily uh it's not going to help us to do a chest X-ray.